as a neoadjuvant setting in breast cancer. And now second speaker will present by our colleague, Professor Dr. Tariq Hussein.
Good afternoon, ladies and gentlemen. Now we move to Professor Alphonse Tagian from USA. The topic will be cardiac exposure to radiation, the policy of zero tolerance.
All right, I would like to thank very much Hisham for his leadership and the organizers of this conference. It is a great pleasure for me to be here. Actually, I just work in the USA, but I'm originally from Alexandria, Egypt, and was educated in Egypt here. So it gives me even more pleasure to come back here.
Sorry, doctor.
So I'm going to switch gear and we'll talk about the toxicity of radiation therapy and means to reduce it. There is no worse feeling for any oncologist when we do our best for breast patients to assure at least a cure, and 10 years later the patient dies from a complication from the radiation. And the effect of radiation on the pericardium and the coronaries is real. Here is a slide of a pericardium and you could see the fibrous layer here and some adipose tissue. So that's the normal pericardium. And once you have a radiation, a patient who received 67 gray to this part of the pericardium, and you could see that the adipose tissue is completely replaced with fibrous tissue. And again, here is the coronary artery, the LAD, for a young patient who received just 40 gray for Hodgkin disease, and you could see the proliferation of the intima, which is causing some narrowing of the lumen. It can actually cause some death. So the effect of radiation on the heart is real, although we don't see it that often, and I will talk about this in this presentation. So the story started maybe 30 years ago with Cusick, who is an epidemiologist from the UK, who did a meta-analysis of all randomized trials comparing post-mastectomy radiation versus no radiation. So this was before the chemotherapy era. And he mentioned that in the first 10 years, there was no difference in overall survival. But when he updated his study with an extension of the follow-up all the way till 25 years, he discovered that patients who were randomized to radiation actually had an increase in mortality than patients who did not, and he attributed this to cardiac mortality. And here a red flag was raised. And you could see from the same study that overall survival actually was a little bit maintained, but post-mastectomy radiation had a benefit in reducing the breast cancer mortality. But when you look at the increased death, was almost 5%. It was from cardiac mortality. So why is that? It's because the techniques we used in the past, and Dr. Gerard presented very nicely about the importance of technology on not only improving the local control, but reducing the toxicity. A while ago, people used to treat a lot the internal mammary chain. There is no a solid data yet to show that there is a benefit from it. But we used to use photons, so we shoot straight to the heart. And when you have, I don't know if it reflects well here, when you look at the dose volume histogram, a large volume of the heart received a high dose, and this was a big mistake. But nowadays, with the 3D planning, we know where the heart is, we know how to avoid it, and consequently, the complication should go down. So when we talk about radiation-induced cardiac toxicity, we need to know where is this radiation going, how much volume, what total dose, and what dose per fraction. So let's raise a few questions and trying to answer from the literature. Does the cardiac volume matter? I think the best study in the literature answering this question comes from Larry Marks from Duke University, when he took 166 patients and he actually did a SPECT scan before and after radiation. So the SPECT scan reflects the cardiac perfusion. So he did it before, he did it after, and he fused both scans. And he showed very clearly that a lot of patients, they have a defect in cardiac perfusion. Some of it recover and some really stay for many years. And when he looked at the percentage of patients with perfusion defects and correlated this with the time, even volumes of 1% of the left ventricle, 1% of the left ventricle will have some sort of cardiac perfusion, although it recovered. But 1 to 5%, almost 20% of patients had cardiac perfusion defect. And when you have a large volume of the left ventricle, you have even more patients with perfusion defect, almost 60%, and this stayed for 24 months or more. All these perfusion defects were anterior, corresponded to the radiation field, and very likely microvessel injury. Now, he wanted to see what's the implication of this perfusion defect. More patients have wall motion abnormalities when you have a perfusion defect than when you don't have. So there is some effect here. More patients had chest pain when the perfusion defect was present. And more patients had actually a reduction in ejection fraction more than 5%. Almost 1/3 of the patient had this reduction when perfusion defect was present. Now, the second question is, what is the target? And there is a very beautiful study coming from Netherlands. They actually looked at their a cancer registry in women who were treated with radiation sometime and developed some sort of cardiac event which triggered an angiography. And they tried to fuse the angiography with the radiation field. So here in their paper, which was published just a year ago, you could see the LAD just in the radiation field. And they looked at the LAD, the RAD, and all the different types of coronaries, and they tried to match this with the radiation exposure. And the most important results here is in the non-irradiated patients, the risk of a LED effect was actually close to 1, which there was no effect. But in women who received radiation, there was an effect almost with an odd ratio of 7. And this is the degree of the effect on the coronaries, and this is the LED and its branches, which shows very clearly that the coronaries are the target. And when you treat the left side, a lot of time the LED is in the radiation field, and we have to be careful with that. Even if you contour the heart and you have 1% of the volume of your heart in the radiation field, so what is this 1%? If it is the right atrium, that's okay. Maybe there is no effect. But if your coronary is there, it can cause a problem, even if the volume is very small. And this is very important for radiation oncologists to really think about. Now, the third question is how long it takes for cardiac toxicity to show up. When you look at the literature, a study from Michigan with a follow-up of just 6.8 years, and the authors stated that there was no increase in risk of ischemia, I think you should take this with a grain of salt, because this is not enough follow-up for the cardiac events really to be obvious. And then when you take these 10 years, still a little bit short, but when you start to see 12 years or 15 years, you will see the separation and you will start to see this cardiac event. And again, the best study in this issue comes from Netherlands, again, who are extremely, really good in addressing the cardiac exposure to radiation. They studied more than 4,000 patients who survived 10 years. So time zero is patients who survive 10 years, and there is actually nothing going on all the way till 12 or 13 years. And here, the congestive heart failure risk starts to separate. Here, no treatment, CMF only, CMF and radiation. So it takes long time. And that's why we, radiation oncologists, we probably don't see these patients, because you treat the patient today, 10 or 15 years later, she develops a cardiac problem, she goes to her cardiologist, and she forgot completely about the radiation. And we have to be careful with that. And this is a study from Sarah Darby from Oxford, looking at the SEER data, more than 300,000 patients, showing very clearly that you need long time to really see the effect of the cardiac exposure to radiation. Now the following question: has the risk of cardiac toxicity decreased over time? And you will see a lot of publications saying modern technology, modern era, we don't see this risk anymore. So again, the study from Netherlands looking at two different eras, from 70 to 79, 80 to 86. So they drew the line in 1980. And you could see the risk of myocardial infarction and congestive heart failure. Quite a lot of p-values here in the old era, and much less p-values here in the sort of like what they called a modern era. And here is the types of radiation and the number of fields. You could estimate that with more radiation fields, there is more exposure to the heart. And the same thing here from the same paper from Darby. She divided this into three different eras. And I just want to bring your attention that in the last era, where there is no increase in toxicity, the follow-up was very little. So we have to be careful with that. A study from Harvard, J. Harris group, showed that within the first 12 years, there was no increase in cardiac-related mortality within at least the first 12 years by talking about using modern techniques. And there is no definition what modern techniques means. But Larry Marks really questioned this modern technique and decrease in cardiac events by saying that all the trials, and he did really general review, with a median follow-up of more than 10 years, reported excess cardiac mortality risk regardless of the trial start year. Even if you start your trial in 1995, you could still have increasing cardiac events if you have enough follow-up beyond 10 years. So we should not rely on the information saying, modern era, there is no cardiac toxicity. That's not true. Modern era reduced the cardiac toxicity, but it's still there. Now we are in an era where we give a lot of cardiotoxic drugs. We give adriamycin, Taxol, and Herceptin. And we should assume that with more cardiotoxic drug, any exposure of the heart to radiation might cause an increase of cardiac events. Now, what are the factors affecting the long-term cardiac morbidity? I mean, some people talked about smoking, so we have to be careful when we have patients with a history of smoking. Some people talked about hypertension or irradiation of the internal mammary chain. Now, question number 5, is the risk for cardiac toxicity similar for all patients treated for breast cancer? And patients have different anatomy. Some patients might be lucky, and with just no maneuvering, the heart is in a location what we call favorable cardiac anatomy, and you can do your tangents without touching the heart. Another patient might be unlucky with what we call unfavorable cardiac anatomy. And here, if this woman has a T1 and 0, you are actually causing more harm than good, because she can be cured from her T1 and 0, but on the other hand, you are treating quite a bit of heart. So we have to be careful with that, and we have to balance the way how we treat patients based on their cardiac anatomy. So to summarize, radiation-induced heart disease is real. It happens. We probably don't see it because we, radiation oncologists, we don't follow the patients for 15 years, but it is there. It's often subclinical and takes very long time. Cardiac effect, cardiac perfusions has been shown that actually the data from Larry Marks showed that 100% of women who received radiation with a sort of cardiac exposure plus adriamycin will develop a perfusion defect. Small irradiated volumes and possibly low doses can also cause some perfusion defect. More technology in radiation planning and delivery tools, it is better, there is no doubt about it, but it is not perfect, and we still need to give attention to the heart. We should be aggressive in shielding the heart and doing all what we can do to protect the heart. Radiation oncologists should still be aware of the potentially increased risk of cardiovascular disease following radiation in the long-term survival. And again, people who say we are treating the right side, we should probably there is no way the heart will be exposed, but when you treat the IMC in the right side, you still expose the heart, and you need to pay attention to that. And radiation and chemotherapy now, a lot of people are receiving chemotherapy, maybe this actually might double the risk. So what should we do? We should do our best to decrease the cardiac exposure to radiation by using partial breast radiation, for instance, in selected patients, using decubitus or prone position, breast hold technique, gating, or proton therapy. So to go over them very briefly, partial breast radiation, assume this woman has a T1 and 0, and she will be cured from her cancer. You give your 2 tangents, you have a lot of exposure to the heart. Again, you cause more harm than good. But you give partial breast radiation, you reduce significantly the cardiac exposure to radiation. Prone technique, mostly used in New York and some other places. Decubitus, lateral decubitus technique, to my knowledge, is only Institut Curie which is using it. So not well propagated. You could do active breathing control and IMRT, and there are data showing that there is protection to the heart. But the technique which I usually use is very simple. It's just breath hold in deep inspiration. All what you need to do just to ask the patient to take a deep breath and hold it, usually for 1 tangent, which will take maybe 16 to 18 seconds. And usually patients do well with that. And you could see that the left lung expand and push the heart backward. And you could draw your tangents really in a more safe way. And this is a fusion of the 2 CT simulation with and without breath hold, and you could see for some reasons the lung will wrap around the heart will be pushed backward, and you can actually draw your tangents by protecting the heart. A very simple technique can be used in order to protect the heart. Some other techniques, you just protect the heart with a protection here, like putting a lead protection, very simple, but you have to be very careful with that. I use this technique in very early breast cancer when the location of the seroma is in the upper outer quadrant. But if you have a high-risk patient with LVI, with EIC, with large tumor, you should not do that, because it was reported in the literature by Larry Marks that he had 2 patients who had local failures behind the protection. So this technique, although it's simple, but not for everybody, you have to be careful with that. And at the end, the technology, the proton treatment, and we have been using proton for left breast advanced cancer in women who have unfavorable cardiac anatomy, and we have a protocol for that, have almost 30 patients. So this is a difference, a comparison between photon treatment or photon and electron treatment when you need to treat the whole chest wall with the IMC and this is the distribution for the protons. And we quantified the exposure of the heart to radiation, comparing the 3 different techniques. With protons, actually, the exposure of the heart is 1/10, 10% of the exposure in the 2 other techniques. We use it also when we have immediate implant reconstruction. So technology can help. So at the end, there is a gap in knowledge in the structure at risk and the mechanism of damage in radiation-related cardiac disease. Not too much really research in this area. It is uncertain whether there is a threshold dose of radiation to the heart below which no risk is induced. And I want to really underline that. You might see some literature saying the heart can tolerate mean dose of 5 gray, mean dose of 3 gray. I wouldn't believe any of those, because this data is based on women who were treated 10 and 15 years ago. And 10 and 15 years ago, there was no Herceptin. There was no probably Taxol. So the data based on 10 and 15 years ago probably should not be applied to what we do today. There is no dose-response relationship. There is no known tolerance of the heart. We cannot say it's too gray, it's all right. No, we cannot say that. There is no data for that. The knowledge about the shape of the dose-response relationship and factors that modify it is very little in the literature. And all the data so far is retrospective and lack accuracy of prospective studies, and we actually need, now we have the technology of 3D treatment, we need to work on this issue prospectively. So until data is generated to tell us what is the tolerance of the heart to radiation, what is the tolerance of the heart which previously exposed to adriamycin, to Taxol, to radiation, we should keep the cardiac exposure to radiation as close as possible to 0. Not only 1 gray, but if you can't do it, it's fine. But you try to fine-tune your technique all the way until you bring this exposure very low. Thank you for your attention.
Thank you very much, Professor Alphonse, for this excellent presentation. And now it's my great pleasure to introduce one of my dear friends and the ex-Ancients member. He's carrying the title of USA now. Professor Dr. Muhammad Sheikh, please welcome him. The talk will be Controversies in Radiotherapy and Treatment of Endometrial Cancer.